I'm a head and neck cancer surgeon, and Dr. Lai, who will follow me, is a colorectal surgeon. Dr. Wakabayashi is a gynecological oncology surgeon. And what the three of us have in common is that we're seeing a lot of HPV-mediated cancers here at City of Hope. And so in my practice, for example, over the last 17 years or so that I've been doing otolaryngology, I've definitely seen a change in the face and the epidemiology, the characteristic of the patient who walks through my office. You know, in the past, you know, head and neck cancer was thought to be just solely a disease of smokers and drinkers, people who just, you know, light one up after another and, you know, enjoy their cigarettes with maybe a glass of beer on the side. And that was really the majority of my patients. And even today, that is the majority of patients who get head and neck cancer. However, we've noticed a very interesting trend in the last, 20 years or so, where we actually now have a substantial percentage of patients who are never smokers. And they come in and they have this thing called throat cancer. Now, throat cancer is kind of a vague a term. It can be a lot of different things. I think throat cancer, the way I think of it at least, is the cancers that develop in the very end of the tongue, what we call the base of tongue. The cancers that happen in the tonsil area, and essentially the back of the throat where the palate is. So those throat cancers can be caused by a sexually transmitted virus called HPV. And this discovery has been made in the last 20, 30 years through epidemiologic studies. And it is felt to be due to the sort of liberation of sexual practices in the 1960s and 1970s. People just have more casual sex encounters. And we end up having sex at a younger age, and we end up having more sexual partners as young adults growing up. So the face of a patient who comes to the head and neck clinic these days can just about be anybody. And I want to make this clear that you don't need to be a smoker or a drinker to develop throat cancer. And in fact, HPV, which is a sexually transmitted virus, is the leading cause of throat cancer in the United States these days. People are not smoking as much anymore. They're not drinking as much anymore. And let's face it, this is a very liberal society. And our youth engage in sex, and it's not always protected. And to be quite honest with you, every single one of us probably in this room has had HPV infection at one point or another. So it affects all of us, and it's ubiquitous. It's a virus that's everywhere, kind of like the cold virus. And so the purpose of me being over here is to inform all of you that this virus is actually acquired through sexual contact. It could be oral. It could be even genital to skin to oral contact, or it could be genital to genital contact. But essentially, it's a virus that's transmitted through sexual contact, and all of us have been exposed to it, unlike there's that rare individual who's never had sex, or has never French kissed somebody else, for example. So it's a virus that we've all been exposed to, likely. And most of us don't end up getting throat cancer, tonsil cancer, or base of tongue cancer. Most of us are able to fight this infection and, get rid of it. And it is unclear, really, who is susceptible to cancer formation by this common virus. That's an area of active investigation. Scientists are looking into that. We simply don't know who's susceptible, who's at risk. We know that we are all at risk for exposure to the virus as long as we engage in sexual activity. So in my practice, again, about 60 to 70% of individuals who come in now with base of tongue or tonsil cancer may have HPV-mediated disease. And that's a big deal. And the estimation now is that by the year 2020, HPV-mediated throat cancer would bypass the number of HPV-mediated cervical cancer in this country. So I wanted to make sure that the public is aware of this phenomenon, because people talk about the vaccine that protects against cervical cancer. They talk about the virus that makes, that makes somebody susceptible to cervical cancer, but really there's not a whole lot that is being said, especially in the media, about HPV-mediated throat cancer. This is the #1 epidemic of our time. I mean, it is really very noticeable and obvious to people who keep numbers, study numbers, and this is a worldwide trend. So my feeling is we're going to be seeing more of it, and we're going to be hearing more about it. And in my own practice, I'm going to be seeing more and more patients afflicted with this condition. So the face of head and neck cancer is in fact changing. So 25% of cases in the United States are no longer related to tobacco and alcohol use. And as I stated, it's really a sexually transmitted virus. It's an infection by that virus that is a principal risk factor for that percentage of individuals. And this association is mainly seen for oropharyngeal cancer. And in the United States and in the Western Hemisphere, up to 70 to 80% of head and neck cancers, oropharyngeal cancers rather, are HPV linked. Now, nobody really knew about HPV and throat cancer until this gentleman showed up on the media everywhere, and he happened to be treated by the guy who actually trained me in New York. And this is the face, typical face of, oropharyngeal HPV-mediated cancer. It's usually a gentleman, although women get this too, but it's more common in men by a 3-to-1 ratio. So it's usually a gentleman in his 40s, in his 50s, keeping a steady job, a family man, married, children in their teens, and, non-smoker, who may have had casual sex, in their young adulthood, and maybe had, episodes of sexual encounter without protection, may have had a history of sexually transmitted disease in their years past. That is the typical patient. And I think, a lot of us might relate to that profile of a person. And so, again, it's not always the smoker and the drinker. The throat cancer, and I want to take a moment to clarify here, is cancer that occurs in this area here. This is the whole tongue. The back third, or the very last third of the tongue, is called the base of tongue. And that, along with the tonsils, side to side, are the organs that are susceptible to HPV-mediated cancer development. And it is not really clear why it's this part of the tongue rather than the front 2/3 of the tongue that's susceptible. But the back of the tongue has a lot of invaginations, and the virus has a lot of opportunity to come in contact with the basal cells. And those cells are rapidly dividing, and they're susceptible to virus entry. So at least theoretically, that is a reason why these lymphatic-rich structures in the back of the throat are susceptible. So I put this slide up just to tell you what it is that I'm talking about. It's throat cancer, i.e., more medically appropriate term, oropharyngeal cancer, tongue base, and tonsils. So this is a small, and it's not projecting very well, I'm sorry, but you could see this is an example of a small tonsil cancer. This is the tongue here. You could kind of barely make the tooth. The uvula that dangles in the back of the throat. And this is a typical tonsil cancer. And so how do you know that you have HPV infection to begin with in the throat? Well, you don't. There's really no good test for it. We don't have the pap smear for throat. And hopefully one day something like that would develop, but for now, there is no pap smear. And the other thing is, there is really no, precancerous lesion that develops in the tonsil or base of tongue area that we could see that could forewarn us that, look, cancer's in the future. So we don't really have any good screening tests for oropharyngeal cancer. So unfortunately, patients come to our attention once they develop symptoms and their diseases progressed further along. The most common presentation is somebody who comes in with a lump in their neck. They feel great. They have no symptoms, no pain, no difficulty breathing, no difficulty eating, and all they have is this pesky lump in the neck that's been there, let's say, for 4 or 5 months. Primary care doctor gives a course or 2 of antibiotics, and the mass doesn't go away, it doesn't regress. It always happens like this, sorry. So that's the most common presentation. It's just a painless lump in the neck that's there and slowly grows. Less common is difficulty with swallowing. Difficulty with swallowing or dysphagia, sore throat, ear pain. You can have weight loss if you're not eating very well because it hurts when you swallow. You can have some bleeding if you have an ulceration in the back of your throat. And if the tumor is really large, it can certainly cause the voice quality to change. But those are less common. By far, the most common is just a lump in the neck. And so, how does cancer develop? Just briefly, the virus is this small particle. It's a double-stranded DNA virus, kind of like your genetic material and my genetic material. It's double-stranded DNA. So the virus somehow manages to get inside the cell. And most of the time, a cell that's infected, the virus kind of stays in this quiescent state where it doesn't really do very much. It's just sitting there and doing nothing. But some trigger happens, and the virus somehow manages to integrate into the host genetic material. And that's when it starts revving up production of some of the cancer-causing proteins. And so E6 and E7 are the notorious oncoproteins or cancer-causing proteins that are part of the HPV machinery. And what these 2 oncoproteins do, they interact with some of our suppressor genes or tumor suppressor genes. These are genes and proteins we have that protect us against cancer. They detect DNA damage, they regulate cell cycle. Somehow, E6 and E7 manages to interact and paralyze those proteins so that they're not doing their job anymore. And subsequent to that, the cell undergoes this, uncontrolled genetic reproduction and, uncontrolled division, and we have essentially, a cancer situation developing. And just before I leave this slide, one of the tests we use clinically to find out if HPV is in fact a player for cancers is this protein P16. Through this interaction that I just went through, one of the bystander effects is that this particular protein expression goes up. And so how we in the laboratory test for HPV is we take the tumor samples and we take it to the path lab, and they essentially do immunohistochemistry and to find out if this protein is upregulated, if it's expressed on the cancer cells or not. If P16 is positive, then we make this big assumption that, the tumor is HPV mediated because of the very strong correlation there. So that's a quick and easy and relatively cheap way that we test for HPV. So how is oropharyngeal cancer treated? Well, to a great extent depends on when you diagnose it. So if it's caught early, which is rarely the case, then either surgery or radiation alone would be sufficient. If you catch something small, like that small tonsil cancer I showed, you can go ahead and cut it out. You can do it with laser. You can do it with a robot. And, at the same time, you have to worry about the lymph nodes in the neck. So cancers of the throat have a very rich lymphatic system. And cancer develops not just there, but it has the opportunity to travel. So it gets into the lymphatic system, and it can find its way to the nodes in the neck. So a very important part of treatment for oropharyngeal cancer is treatment of the neck nodes. So if it's caught early, you can operate on the back of the throat using laser technology or robotics, which we offer here at City of Hope. And you can do a safe and very effective neck dissection and remove the lymph nodes with very little side effects as far as the patient is concerned. And that will be a complete treatment with better than 90% survival rate. Or you can certainly treat that with radiation. You can treat the primary site with radiation. You can give high-dose radiation to the neck. So radiation is also a reasonable option. But remember, radiation is only a one-time possibility. So you can't radiate the body twice, at least the same area of the body twice. So if you have a modality that's very effective, like surgery, you want to use it. And keep radiation for the day and time that maybe something in the future happens, so you have that lifeline still available. Most of the patients present with advanced stage. As I told you, the most common presentation is a big lump in the neck. And as soon as you have a lump in the neck, you're stage 3, you're stage 4. And so single modalities are not sufficient anymore, and we need combination of treatments. So we combine surgery sometimes with postoperative adjuvant therapies, and adjuvant is a big word, essentially means what follows surgery, or the treatments to follow a primary treatment. So for advanced stage, you can have the option of surgery again, where you go ahead and cut out the tumor, take out the lymph nodes, and then you study the specimen, you look at the pathology report, and based on the risk stratification, you can decide whether this patient needs additional radiation therapy, whether the patient needs additional chemotherapy too, and obviously you can put that together, and you can offer that as a comprehensive treatment plan for your patient. And certainly there are instances where surgery upfront is not the best choice for the patient, and there are a number of reasons why that might be, and we can go into that later on in the Q&A discussion. But we can certainly combine chemotherapy with radiation and have, equal efficacy. The good news is most of our patients with HPV-mediated throat cancer have excellent prognosis. So if the tumor is caught early, T1, T2, T3, kind of early volume disease, a survival rate of over 90% is expected. And this is very different than the tobacco and alcohol-mediated cancers in the same organ, where, if you have a stage 3 tobacco-induced tonsil cancer, the 5-year survival, is not as good as 60%. So, HPV-mediated throat cancer has a better outlook. And honestly, there are a lot of theories why that is. We think the genetic machinery of the host cell is still, for the most part, intact. And for that reason, we think that the HPV-mediated cancers fare better than the tobacco-mediated cancers, because the tobacco exposure causes a lot of genetic aberrancies. And so the cell that becomes cancerous through tobacco consumption has a lot more abnormalities going on through different cycles of regulation. So HPV-mediated throat cancers also tend to be more sensitive to chemotherapy, to radiation, or surgery, whatever you throw at it. So this is kind of an interesting phenomenon. The interesting thing that just came out from a recent meeting, actually just came out at a multidisciplinary head and neck meeting over the last 24 hours, was an abstract presented by Dr. Fakhri from Johns Hopkins, where even in the recurrent setting, so let's say you've had HPV-mediated tonsil cancer, and you've gone through the standard therapies and you develop a recurrence. So even in that setting, your prognosis is better than somebody who has a recurrence of the same cancer but who acquired that cancer through tobacco consumption. So that is obviously promising, and it's good news. I talked briefly about some of the surgical modalities of treatment that are available. In the past, all we had in terms of surgery to offer these patients were big operations where we'd have to split the jawbone, swing the jawbone out, get to the back of the throat to remove these tumors, and then we'd need a reconstructive surgeon like Dr. Kang to come on in and try to rebuild the back of the throat so the patient can talk and swallow again. So that was the way we used to do it. And that would require a tracheotomy. Oftentimes, it would require a temporary feeding tube. And once the patients recovered from that big surgery and big hospital stay, oftentimes there was still a recommendation for 6 extra weeks of radiation to follow. So you could see it wasn't a very attractive sell for the patients. In the last 8 years or so, minimally invasive surgeries are becoming more and more prevalent in this country. And there are academic centers that offer it to our patients with oropharyngeal cancer. We offer it here at City of Hope. So if you have the right tumor and you have the right patient, so selection criteria are very, very important, then you can potentially go ahead and do a very nice job without putting any scars on the face, without really splitting the jawbone, without needing to do a trach, without needing to give a feeding tube, without needing sophisticated reconstructive surgery, go ahead and either with a robot or with a microscope and laser, cut these tumors out. And hospital stays are shorter, patients suffer less pain, and they regain function much quicker. And so it has been shown that these techniques, when they're applied to oropharyngeal cancer, really by 1 year, patients have near normal speech and swallowing function. So we talked about HPV-mediated oropharyngeal cancer having really an excellent chance of cure. And because the prognosis is so good, the goals of therapy are multi-pronged. Obviously, we want to cure everybody. But secondly, we want to do it in the least invasive and least toxic manner. And now we have, better radiation regimens. We have easier chemotherapy protocols, and we certainly have novel surgical technologies that allow us to do a better job and to try to really de-intensify treatment so that the patients don't suffer major toxicity burden and side effects from heavy-duty treatment. So that's another very, very important goal in therapy, because think about it. You have a 40, 50-year-old gentleman who comes to your clinic with his tumor. I mean, what if you gave him chemoradiation, let's say, and he happens to be the 1 out of 10 individuals who won't be able to swallow safely again for the rest of his life? So, I mean, that's not good quality of life if you can't share a meal with your family members. If you can't have a Thanksgiving meal, I mean, that obviously, is not an ideal outcome. So we want to individualize treatment, and we want to make sure that we optimize the chances for cure, but we also want to make sure that we leave the patient as unharmed as possible and as close to baseline functioning. If anything, we want to improve function with the larger tumors that we remove. And lastly, before I hand it over to Dr. Lai, there's a lot of stigma attached to a diagnosis of HPV-mediated throat cancer. If you were the patient, you're sort of getting double bad news. You get the news that you have cancer, and that's frightening in and of itself. What that means. Am I going to live? Are there treatments available? What am I going to expect through treatment? Am I going to get disfigured? Am I going to get mimed? I mean, what is my life going to be like? So you have those sets of anxieties to deal with. But then you also have, a label of a sexual transmitted disease. You don't want anybody looking at you as a sexual deviant. And so it is really important to, wipe away misconceptions about HPV, because HPV is everywhere. and almost everybody's been exposed. So it's the same virus that can cause a wart on the skin, and I don't think there's much stigma over there. So it really doesn't make sense, for patients to feel personal guilt, shame for having this disease. Sometimes they feel really bad because they think, they're a risk factor to their loved ones. I have HPV tonsil cancer. If I have intimacy with my wife, is my wife going to get HPV-mediated throat cancer? And, obviously they don't want to live with that guilt. Am I a risk to my children? And so part of my job as a clinician, especially if I'm going to test for HPV virus, is to educate. And my job is to educate to make sure they understand exactly what the implication of the HPV status is. They are not a threat to the society. We don't know when you got it, how you got it. Somewhere in your past, you were exposed to it. It's a virus that's everywhere. We're all human, and we enjoy human-human interactions. And somewhere along the way, you were exposed. What made you susceptible, we don't know yet. Scientists are trying to figure that one out. The good news is the cure rates are excellent, and nowadays science and technology has evolved to the point that we have, easier treatments, that have excellent cure rates, and we're able to maintain functionality and vitality for the patients. This third component, I think, is very important because you don't want your patient leaving the clinic and wondering, what does this mean? Am I going to transmit this to my spouse, to my significant other? Can I kiss my daughter on the cheek? So it's really important that you have that educational component of interaction with the patients. This virus exposure must have happened 20, 30 years ago. Who knows how you got it? Who knows, when you got it? It's not really clearly known. The exposure may have happened as a teenager. It may have happened when you kiss your first boyfriend or girlfriend. And so, you can't really put blame on anybody for that. And so it's very important that you discuss that with your patients. In my practice, seeing so many HPV-mediated throat cancers, I've never seen a spouse that has HPV-mediated throat cancer too. So I want to make sure it's clear that HPV tonsil cancer is not infectious and it's not contagious, meaning that, if I have tonsil cancer that's HPV-mediated, my spouse isn't, at any additional risk of getting HPV-mediated tonsil cancer than somebody else in the general population. So us in the medical community, we simply don't have any foundation to recommend changes in social interactions or behavior. And we recommend that you continue, with, your loving relationships. Obviously be smart. If you have children, vaccination is important. And we're going to talk about this again more maybe in the Q&A session. But, there's a vaccine that's very effective against this virus. And it was approved to be administered to teenage girls in 2006, and then it was recommended that boys be vaccinated too as of 2011. And so it's a series of 3 vaccines that are given. The recommendation is that it be given, around the age of 11 and 12 before we start becoming sexually very active, because it's a preventative vaccine. So once you start engaging in sex, you have the exposure already, so it can't be protective. So you want to start early. You want to vaccinate kids early. And so you want to catch them before they're going out there and having, sexual relationships. It's important that we educate parents that if they have, children in that, susceptible and fragile age group, that's the time for them to learn more about the vaccine and to encourage, their teenagers to participate in the vaccination program. It's a 3-step vaccination, three-step vaccine. The vaccine has proven to be safe, and it requires 3 visits to the pediatrician's office, so 3 doses. Day 1, and then 1 a month later, and then the last one is within 6 months. So you want to complete the series, within 6 months. The sad news is, and what's really bothers me, is that the compliance with this vaccine is very low in this country. And so only about 1/3 of our teenage girls are vaccinated. And for boys, only maybe 10% of teenage boys are vaccinated. So if you look at other countries worldwide, they have vaccination rates in excess of 70, 80%. And already they've demonstrated that in areas where there's success with vaccination, the HPV prevalence is being reduced. So we have something that's safe and very effective and can potentially be preventative as far as cancer is concerned, not just throat cancer, but cervical cancer and anal cancer too. I think education is really, really important, and I hope that I was able to share some of my perspective with you effectively, and that you benefited from this little session. I will be followed by Dr. Lily Lai. She's Associate Professor in the Department of General Oncologic Surgery, an excellent colorectal surgeon with a lot of expertise in HPV-mediated rectal cancers, anal cancers. So I'd like to welcome Dr. Lai to the stage.
Well, there's not much that I need to say since Ellie has given such a comprehensive talk already, and I really appreciate all that she's talked about. I wanted to specifically talk about anal cancer, and it's always apropos that I bring up the end of the talk. I also wanted to show you a face of anal cancer, but unlike Ellie, if you really saw the face of anal cancer, that would be not a good thing. So I thought I'd show you the face of anal cancer by showing you Farrah Fawcett. Now, Farrah Fawcett, most of you know. The really young kids have no idea who she is. But she was such a big TV star in the 1970s and 80s. And she ultimately did acquire, she did develop anal cancer, although it was not really known until after she died. And she ultimately died from it. Since then, though, there's a Farrah Fawcett Anal Cancer Foundation that is really giving money to do good research in HPV-related anal cancer. All right, so what is anal cancer? And we talked a lot about head and neck cancer. You saw the picture of the oropharynx. Well, this is the other end of the GI tract. And if we really talk about anal cancer, it's really a very limited space. Just like oropharyngeal cancer is very limited to the base of tongue and the tonsils, anal cancer related to HPV is really limited to a small area in the end of the end of the GI tract. So this is really the anus. So if you were to eat, everything goes down your esophagus into a bunch of small intestines. Everything goes through your colon. Your colon starts on the right side, comes up, comes across, and then everything ultimately goes down and goes out of your anus, which is represented here in this cartoon. So if we looked at this, the anal canal is defined as the opening, the anus, up until about 4 to 6 centimeters above the anus into the rectum. That area is known as the anal canal. So it's not a lot of territory. It's not a lot of real estate. But that area is what we're talking about when we talk about anal cancer. And most of the time, anal cancer is made up of squamous cell cells. Squamous cell, it's from the squamous cell that the cancer develops. It's a big word. You don't really need to know about it, except that these are the same cells that become cancerous in the oropharynx, and most of the time it's the same cells that become cancer in the cervix. There are other types of cells in this area, but again, 85% of all the anal cancer is from this cell called squamous cell. It's also known as basaloid, coagulogenic, or transitional. All right, but anal cancer is very unusual. It only represents 1.5% of all gastrointestinal GI cancers. And in the United States in 2013, there were only 7,000 new cases. Now, you have to think about this in terms of colorectal cancer. In colorectal cancers, in the year 2013, we had about 150,000 cases in the United States. So this is a small number. And the risk factor, the number one risk factor, is HPV infection. About 80 to 90%, 95% of all anal cancers, if you look at them and you look at the genetics in that cancer, you can find HPV genetics in that cancer. So it is found in 80 to 95% of all anal canal cancers. Other risk factors are actually similar to oropharyngeal cancers, which is that cigarette smoking is one of them, but that's probably related to lifestyle, anal intercourse, multiple sexual partners, which I didn't put up there, early sex, and also immunosuppression. So that in patients who have HIV infection or the virus that causes AIDS, this group of patients have about a 35 times increased risk for developing anal cancer. In patients who've had a kidney transplant or a liver transplant or even a bone marrow transplant have increased risk for developing anal cancer. And that risk ranges between 7 to 15 times the average risk for the average individual. But why are we talking about this? We're talking about this because HPV is increasingly prevalent, as Ellie talked about, but also because there is an increased incidence in anal cancer. Just as she was talking about that there's an increased incidence in oropharyngeal cancers, and that by 2020, it's going to eclipse all the cases of cervical cancers. Well, it's going to be a while before anal cancer gets there, but it's rising, and it's rising fast. This is really just a graph of time. This is from 1973 to 2009, and these are the epidemiology of, of anal cancer. If you look at this blue line, it's the incidence of anal cancer cases in men. The red line is the incidence of anal cancer in women. And you can tell that 0 is nobody has it, up to about 3 per 100,000. If you follow these lines out, you can tell that there's been a rise in the number of cases. And somewhere around the mid-90s, the rise it gets a lot steeper. So there's an increased rate of the cancer developing. If I were to put this in a little bit different kind of a graph, but the same idea, from 1973 to 1997, you can tell there's been an increase in the incidence of the number of cases per 100,000 people. It goes from a little less than 1 to about 1. And it is true for both men and women. But after 1997, you see the steep rise in men, almost 2.3 times what it was before. So in 2009, it's about 4.5%, 4.5 per 100,000, whereas before that it was just over 1, and also in women. And this argues, again, there's been some change in our society, whether that's sexual liberation, whether that's HPV, whatever it is, there was a definite difference in the incidence rate of this cancer. And if this continues to go upwards, it's almost exponential for men. Who knows what it will be in terms of predicted values. Now, I brought this up, and I apologize, this isn't very clear. This says women and men. What it shows is that if we looked at each of the stage of anal cancer, so going from in situ disease, which is a precursor for invasive disease, much like breast in situ disease and invasive breast cancer, if we look at in situ disease in women, localized squamous cell cancer, regional, and distant, they've all been rising pretty steadily from 1997 to 2009. But if we looked at this in men, the stage that has seen sort of astronomic rise is actually in situ disease. Although the other stages have increased over time, what is really interesting is that the in situ disease have gone up markedly. And I think that that's related to some sort of anal cancer screening in men who have sex with men, as well as in the HIV population. Even though we know that there may be an association with cervical cancer, women are not getting screened for anal cancer. Women who have cervical dysplasia are not getting screened for anal cancer. And there's no systematic screening program, even for women who are at risk for developing anal cancer. So what are the relationships between cervical and anal cancer? I think Ellie did a great job telling you the links between HPV and oropharyngeal cancer. Well, similarly, there's a link between HPV and cervical cancer. And in fact, it was in that group, and I'm sorry Dr. Wakabayashi isn't here because he would have gone over that at greater detail with you. But it was that association, that relationship between HPV and cervical cancer that everybody began to look at in terms of, or sort of took from that to try to understand what was happening with anal cancer. So the risk factors are the same. Again, multiple sexual partners, early age of sexual activity, immunosuppression. All those are similar risk factors for anal and cervical cancer. And in women who have cervical dysplasia, that is, any changes in their cervix, whether it's precancerous or even cancerous, will have an increased risk of developing anal cancer. This has been shown in epidemiological studies. 90% of women with cervical dysplasia will have anal HPV infection. So if you were to test their cervix for HPV and you were to test their anus, the anal canal for HPV, they will have infection in both. And in addition, they have the same subtypes. So HPV, there's about 100 or more subtypes. They're identifying more subtypes all the time. And there are ones that are what we call oncogenic, or will cause cancer. Specifically, those are 16, 18, 6, and 11 maybe. But there are other ones that don't cause cancers. Those are the ones, 6 and 11 actually causes warts. Those are the ones that will cause warts. Though they're benign, they almost never become cancer. It's the 16 and 18 subtypes that will. There's other ones that are only beginning now to be described. And the literature shows that HPV as a virus will then sort of settle in these anal genital areas and become reservoirs so that there's serial exposure of one site to another site. All right. Well, so what are the signs and symptoms of anal cancer specifically? In fact, most patients present without symptoms, and I put this last, I should have put this first. But the symptoms are very similar to almost hemorrhoids, which is why they often get confused with hemorrhoids. Bleeding with bowel movements, bleeding on the toilet paper, bleeding in the toilet bowl, pain and irritation at the anus, and maybe even a mass with an ulcer, a painful mass. Any of those things would argue that you should go and see a doctor and get evaluated. But even without symptoms, there is some risk, whether you have cervical dysplasia, oropharyngeal dysplasia, you have immunosuppression, you should actually be seen and evaluated for anal dysplasia. And treatment. Well, so much like oropharyngeal cancer, treatment was really surgical until about the 1970s. And at that time, what we did was we removed the anus, removed the anal canal, and the patient ended up with a bag, a permanent bag for the rest of their lives. Of course, this affected function, but it did result in cures from this cancer. But starting in about the 1970s, people began to give chemotherapy and radiation together to treat these cancers. They were exquisitely sensitive to what we call chemoradiation. And in the first series, 3 patients that was published in 1974, 2 out of the 3 patients who were treated with chemoradiation did not have any cancer when they went to remove the anus and the anal canal. And the 1 out of 3 of them said, "I'm not having this operation, thank you very much," and he survived. And in a subsequent series, 28 cases later, they did the same treatment, chemoradiation, and 50% of them, 14 out of 28, did not need a bag. They were treated without needing a bag. This has become the standard of care for anal cancer. So the patients who present with anal cancer are treated first with chemoradiation. And about 80 to 85% of them will respond so that they will not need a surgery. Surgery is really for salvage if they have residual disease or they have recurrent disease. And what this has resulted in is actually very nice, and this follows in line with Dr. Maghami's talk as well with respect to function. So these are curves again. On this line is time. On this line is the percent of patients living without an end bag or without a colostomy. In the 1970s, this was the first decade, in the 1970s, only 35% of patients lived without a bag. That means if you survived your anal cancer, 75% of the time you would have a bag, but you would survive your anal cancer. By the 1990s to 2000s, 75% of all patients survived without a bag. They were surviving with their anus intact. So this is really my last slide to go to show that in the 3 decades, we've made a lot of progress. What we only are beginning to really recognize is the relationship of HPV to anal cancer. And this is really within the last 10 years or so. And it's because we have a better understanding of cervical cancer, we have a better understanding of oropharyngeal cancer, so that now we can wrap all these cancers together as being linked to HPV. What we don't know, and Ellie alluded to this, is why some people are at risk for developing cancer, and most of us who are exposed to HPV are not. Whether that's because there's persistent virus, whether there's an immune part to it. Certainly the immunosuppressed patients have a higher chance of getting this disease, or whether there's something else that we don't know. But what seems to be true is that with the vaccine, it's been the benign genital warts are almost completely gone in the kids, in the girls that have gotten all 3 vaccines. It would argue that those vaccines that target subtypes 16 and 18 likewise could somehow prevent these cancers from developing. We don't know that. It will take years to really find out, but if the benign lesions are any indication, it would argue that the malignant lesions would likewise be prevented with the vaccine. Well, thank you very much for your attention.